Good morning. Today we'll have a case discussion on carcinoma tongue. The case will be presented by Dr. Ronit Seal, who is a second year junior resident at IPGMR SSKM Hospital. And today our moderator will be Professor Chintamani. Ronit, you share your screen, present up to the history. Wait, we have some discussion on the history part and then pass on to examination and subsequent management. Ronit, you can share your screen.
Dr. Ronit, you are muted.
Mehul, I can't hear you properly.
Okay. Let's start, Dr. Ronit.
I can't hear him. Has he started?
Ronit, you ready?
Sir.
Please start.
Yes, you are audible.
Good morning, respected Professor, and I will do the carcinoma talk. Next slide. This is clinical picture. Mehul. Can I go to the next slide, please?
Check your audio. Keep the video off and then see.
Okay, so coming to the patient particulars, my patient Mr. Ashok Das, a 35-year-old Hindu male cab driver hailing from Kolkata. And next slide, Mehul.
Can't hear him. I hope his audio is okay.
See, but sir, I am continuing with the presentation. I cannot see. Sir, can you hear me?
Your sound is breaking. Just see the sound.
Hello, sir, can you hear me now?
Yeah, better.
Yes, now it is clear. Please continue.
Okay. He came with a chief complaint of ulcer on right side of his tongue for the last 4 months. Coming to the history of present illness, patient was apparently well 4 months back. When noticed an ulcer on right side tongue while brushing his teeth, which was insidious in onset. a pinhead to current size of approximately 1.5 into 1.5 centimeter. It was not associated with pain, excess salivation, or decreased mouth opening. No history of changing distant metastasis. Coming to the past history,
Dr. Ronit,
engage no. Sorry, sir.
you are not audible in between. Just see
Yeah,
the audio.
I think if you switch off your video, maybe the audio would improve. Run it.
Okay, sir. Okay, sir.
Video आपका correct.
Is it better now, sir?
Yeah, better now. Please start.
Now it is
Carry on.
better.
Okay. Today, repeat the presentation, sir. The past history.
Again, some issue.
Hello, sir.
Yeah. Hello.
Yes, sir. Am I audible now?
Yeah, audible. Carry on. Please carry on.
Okay, sir. So, by
better net connection.
hello.
Yeah.
Doctor.
Sir, should I repeat the history of present illness or should I carry
No,
on from past history?
No.
You carry on.
You start from the last slide of history of present illness.
Okay, okay, sir.
This is okay.
So,
And then next, yes, start from here.
okay, sir. So, no, patient gives no history of radiation exposure, no history of difficulty in chewing, swallowing, or speech articulation, no history of change in voice, loosening of teeth, no history of whitish or reddish patches noticed prior to development of ulcer, no history of any swelling in the neck, no history of weight loss, or no history suggestive of distant metastasis. Past history, there was no major illness, no previous surgery, no history of exposure to TB, and no comorbidities. Coming to personal history, the patient has a history of tobacco chewing for last 10 years, approximately 5 packets of quids per day. Patient does not smoke, but patient also is intakes alcohol for last 10 years on an average 120 ml per day. Patient gives no history of high risk sexual behavior, no history of injectable drug intake. Patient takes mixed diet, sleep, bowel, bladder appetite is normal, and no history of any allergy to any food or drug. Coming to family history, no similar disease in any other members in the family, and no history of malignancy in family members. Sir, I'm continuing to general service, sir.
Okay.
In the history,
Yes,
in
sir.
the history,
Yes. Go ahead.
although it was very sketchy, but I could pick up some point which I can share. One is I never mentioned the name of the patient in the history. It's a cardinal sin. You can be in trouble. Okay. So that's
Okay.
one thing. You don't need to mention it. And mentioning anybody's name doesn't make a difference in your presentation. That's number one.
Okay, sir.
Can you go back to the first slide? I mean, that's how we'll at least be able to revisit what you presented. So ulcer on right side of the tongue is what the patient had. That's right. That's perfectly
Yes,
okay.
sir.
Now, Mr. Ashok, etc., was not required. That's what I was saying. And then
Okay.
come to the history of present illness. Next slide. Quick. Next slide.
Male.
Yeah. Well, you've taken down too many negative histories, which is good, but a lot of them may not be relevant, right? So, but when you say no history of exposure to radiation, you got to qualify. I mean, exposure to radiation is not something very usual. So that would only happen either, which kind of radiation would normally precipitate a second malignancy? Low dose, not high dose, right? And low dose
Yes,
radiations are not used frequently, except in very, very rare scenarios, or if the patient lives close to any nuclear zone or, places where the Chernobyl-like situation. Now, the other thing was difficulty in chewing and articulation. If it is not there, one would be surprised because with such a lesion, patient would have some difficulties. But one doesn't have to really unnecessarily write down things which are not relevant. Are you getting what I'm saying? There'll be,
okay.
if you
Yes,
have
sir.
a tiny ulcer on the lateral side of tongue, also you start having difficulty in chewing and swallowing, but no significant history, which is what you're looking for. So, what did you
Okay.
have in mind? Difficulty in chewing. Why did you want to take that history?
Sir, it was still an early lesion, and it was not painful, so patient did not complain of significant
No, Ronen,
difficulty.
please understand the question. Why did you want to take it in the first place? How does it make a difference?
Sir,
If there is restriction of difficulty in swallowing, what does it mean?
uh, if it is difficulty in chewing, sir, that means
Yeah, yeah.
it may be due to the involvement of the masticator or the pterygoids.
Will that be the first thing? Patient will have many more things like trismus or other features before this mild difficulty, etc. You see, unless you
Yes.
have some specific thing in mind, asking these questions may not make any great sense. Like difficulty
Okay.
in chewing, you should know why you're asking. Because if you don't know why you're asking, then probably you'll be simply asking for the sake of, you know. Because the tongue sometimes gets fixed to the floor. What is that called?
Uh,
When the
well,
patient cannot
sir,
control the tongue?
ankyloglossus, sir.
Right, something like that. The patient's tongue doesn't move. So he'll have difficulty in chewing or swallowing or even articulation of voice. So it gives you an indirect evidence of the extent of the disease. The whole idea is that in this history, not for the sake of asking any question you should ask. That's what I'm trying to highlight. Loosening
Yes,
of teeth. Why did
In
you want to
loosening
take
of
that
teeth,
history? Why did you
yeah.
want to ask that history?
sir.
In which lesion this occurs? In which lesion the oral cavity? You have shown a small ulcer in the lateral border of the tongue.
Right. So please
Will
let
it
us know
cause
why did you want.
loosening of teeth?
Okay.
Yes, sir.
Did you have something specific in your mind? Then it's okay. What was it?
Sir, by a concomitant lesion in the by alveolus would
Yeah.
cause
Okay. So the answer to the question, because we keep in this class, we keep it very focused. One is the extent of the disease. If it is extended onto the floor of the mouth and mandible, then that
yes,
can
sir.
happen. And
Yes, sir.
secondly, there can be concomitant lesion. I agree.
Yes,
Thirdly,
sir.
there could also be indirect involvement. That is, if there is a node in the submandibular triangle, it can erode. So importantly, this history needs to be, if you have this history that is positive, then you can
Yes, sir.
build on it. Otherwise, you should be clear on why you're asking. Now, instead of mentioning whitish or reddish patches, you can be straight. Leukoplakia, no previous history of leuko or
Yes,
precancerous conditions in the oral cavity. So that
okay.
sounds more technical, scientific from a postgraduate rather than these patches, etc. Because these patches alone are not the precancerous conditions. All the moment you mention no history suggestive of any precancerous oral precancers, immediately the examiner is going to ask you what are those. So what are those?
Sir, it could be leukoplakia, erythroplakia, leukoerythroplakia, submucous fibrosis, oral candidiasis.
Right? So you understand the moment you
Yes,
mention something more useful, you get a question which you can answer. Right. So
yes,
this is
yes,
important in your presentation. I'm simply telling you what exactly you could have done.
Carcinoma in the tongue, the change.
yes, sir.
Yeah. So you can, the moment you say there are no oral precancers rather than whitish, reddish patches, this is all crap because you'll
Okay,
have, everybody has some white or red patch anyway. Now,
okay.
no history of swelling in the neck is understandable. You're talking about thinking about lymph nodes. We understand that.
Yes,
History of
sir.
weight loss. Is it common with oral cancers to have significant weight loss?
No, sir, not that common, but
Why is it rare? Let's not waste time. Why is
sir,
it rare?
uh,
Site of getting a swelling in the neck.
Why is it
w-
rare to have weight loss in patients with head and neck cancers?
Sir, I don't know, sir.
Good. That's a good answer. If you don't know, say, I don't know, so that we save on time. Most patients of cancer have weight loss on account of few things. One, either they are not able to swallow, eat, appetite is gone, etc. But importantly, due to tumor necrosis factors, which happen in tumors that grow to large size, and in the center there is a decreased blood supply, necrosis in the center, leading to production of TNF, including one which is, TNF alpha 1, beta 2, 3, etc., and cachectin, which leads to cachexia, which takes away the appetite, and then they lose the appetite. So that is they lose the weight. So they get into that catabolic state. So cachexia is a feature which is not commonly seen in head and neck cancers. Most of them are localized to head and neck. The distant
Okay.
metastases are not common. So when you
Okay.
mentioned, I'm glad you mentioned no history suggestive of distant metastasis. This allows me to ask you one more question. So what are the distant metastasis points in the history that you would get from the patient?
Sir, commonly distant metastasis occurs in lung, liver, and bone.
So simply mention the symptoms. No? So these are the
So
places
cough,
where from. Mhm.
cough, hemoptysis, and maybe respiratory distress, sir.
All right, I understand what you're saying. Similarly, the reddish and whitish patches would not make sense therefore, because here you're being very clever and there you're being very basic. So importantly, no history suggestive of distant metastasis would essentially be bone related, liver related, lungs related, or brain related. That's how you normally take it. Next slide.
Yes, sir.
Now, this is optimum. This is adequate. No problem with this. No major illness, no surgery, no history of exposure to tuberculosis. No common. Why did you take history of tuberculosis here? What is the common site for tubercular ulcers on tongue?
Uh, sir, sir, common site, I do not know, sir.
T for tuberculosis, T for tip, and also the lateral margin. Let's move to the next slide, please.
Okay, sir.
Now, this was important history and you covered it beautifully. There's absolutely no problem. But be careful in mentioning everything. When you're mentioning it, you should be prepared to answer the questions, right? Now, history of
Yeah.
tobacco chewing, but here you need to qualify in what form. Is he a smoker or it's a smokeless form? Because it's
Sir,
important.
in smokeless form, sir, he takes quid.
And then he places where? This becomes important.
Yes, sir, in the lateral sulcus. But
So he should have, why should he get tongue cancer? If he's placing in the lateral sulcus, you should get the lateral sulcus cancer, which is called as the common Indian oral cancer, which is in the lateral sulcus. So why did he get it in the tongue, not in the lateral sulcus?
sir, sometimes,
So, yeah, please.
yes, sir,
Please carry on.
he sometimes places it in between his teeth and
Okay. So
tongue.
therefore, Ronit, you needed to mention he takes
Yes, sir.
tobacco in the form of masala quid and places
Yes,
it between the sulcus, which is between the tongue and the mandible, right? Good.
yes,
And
sir.
why did you take the history of high risk sexual behavior?
Sir, sir, one, there is human papilloma virus is a risk factor for all head and neck carcinomas. And secondly, syphilitic ulcers are a
Okay.
disease.
So got it. Now, how does HPV change the present your understanding of head and neck cancer? Now
Sir,
the AJCC 8th edition has changed it. The HPV cancers are separate from the others, right? It's
yes,
important to
sir.
therefore find out. That's what I wanted an answer relating to. And syphilis is not common, but you're right. The syphilitic ulcers. Syphilis occurs in which stage of syphilis is seen in the tongue? Primary, secondary, or tertiary?
Sir, tertiary, sir.
All three. Primary, gamma, secondary, condylomas, etc. And tertiary is a neurosyphilis, where you find a nerve involvement. So tongue has all three. You get it, including congenital syphilis you can get. You know about it. We will not go there. There's the Hutchinson's triad, which you should read. Let's
Yes, sir.
move to the next slide. Now, this family history is a little, it could have been a little better. No similar disease. This similar disease is a very tired description of anything. What is his disease? Does he know or does she know? She doesn't know. So how will she tell you? So you can be more precise. No history of malignancy in the family is fine. No history of any ulcers in the oral cavity or tongue, etc. That would have been more relevant.
Okay,
Because
sir.
to To say that no similar disease in any other member of the family, it's too complicated and too bureaucratic. Because first of all, we have to find out what is this disease and then to find it out in the other family members. The rest from my side. Next slide. Treatment history. Move to the next slide, please. Now, I think we needed to understand about the treatment history, which you covered up in the previous point. So, what treatment history would be relevant to you?
Sir, in any history of tooth extraction, sir.
Right. Dental intervention and
sir,
What might have been done by
and
this time? What might have been done by this time? She comes to your exam
sir,
table. She might have some
sir,
investigation being done. Maybe she
if
biopsied.
if patient had already presented earlier, then biopsy would have been incisional biopsy might have been done.
basically very
That
rightly
we
brought
could
out
ask.
by Professor Shah, because it's an intervention which you need to mention, right?
Yes, sir.
Yes. Please proceed to general survey.
Sir, patient is conscious, alert, cooperative, oriented to time place person. ECOG performance status is 0. Build is average. BMI 21 kg per meter square. Patient is well hydrated. Normal faces. Decubitus of choice. No pallor, sinuses, edema, jaundice, clubbing, engorged neck veins, or palpable lymph nodes. Vital signs, the pulse is 72 beats per minute, regular, normal volume, arterial wall not thickened, no radial or radiofemoral delay. BP 110/72, measured in right arm in supine position. Respiratory rate 14 per minute, regular abdominothoracic, and temperature is patient is approved by. Coming to the local examination. Patient is inspected after proper consent in a well-lit room in sitting position with proper exposure of head and neck. Mouth opening is 3.5 centimeter approximately. Poor oral dental hygiene with nicotine staining of teeth and halitosis. No missing teeth or sharp teeth. Ulcer noted in right lateral tongue border in anterior two-third, approximately 1.5 into 1.5 centimeters, oval in shape. 2.5 centimeter from the tip with everted hipped up margins but no slough in floor. Surrounding area appears normal. Normal tongue protrusion, ventral surface of tongue, floor of mouth, rest of oral substance, retromolar trigon, and neck appears normal. Local examination, palpation. Inspectory findings are confirmed. Mouth opening confirmed to be 3.5 centimeters. No tenderness on the ulcer in the right lateral border in anterior two-third, approximately 1.5 into 1.5 centimeters. Again, with the inspectory findings, they are confirmed. It is not adherent to the mandible, and base of ulcer is felt. It is intubated. Base of tongue, floor of mouth, alveolar margins are not involved. Tonsil, tonsillolingual sulcus, rest of oral subsets normal. No sharp teeth or loosening of teeth felt. Tongue movement normal, mobile in all directions. Neck, no palpable lymph nodes in any of the neck levels on either side. And indirect laryngoscopy, normal finding was found. Coming to the systemic examination, it was essentially within normal limits. So, sir, to summarize, I have a 35-year-old gentleman who is a known tobacco chewer with a history of alcohol intake, complaining of lesion in the right lateral border of tongue for last 4 months without any pain, restricted mouth opening, tongue protrusion, or problems related to speech or swallowing. On examination, and also infiltrative growth of 1.5 into 1.5 centimeter in right lateral border of tongue in anterior two-third part seen. Provisional diagnosis, this is a case of ulcerative type of carcinoma tongue on
Without
the right.
lymphadenopathy. That you should add. Without lymphadenopathy.
Okay, sir. Okay, sir.
In the summary. Yeah.
Yes, sir. Yes, sir. Coming to the provisional diagnosis, case of ulcerative type of carcinoma tongue on the right lateral aspect of the anterior two-third of the tongue without any lymph node metastasis, sir.
Okay. You again have to go, yes, general survey. So ECOG 0, we will have to see, but that's okay. Decubitus of choice for our oral cavity patient would be what?
Sir, patient is going about his normal day-to-day activity. It is not affecting any.
So So, dear, you don't have to be a copycat. You can't use everything every time. So, decubitus is usually should be affected. No, oral cavity does not affect anybody's decubitus. Okay. So,
Yes,
it
sir.
is, nobody will kill you for this, but I thought since you're presenting it here, might as well add that part. So, don't unnecessarily make it complicated, right? Build is
Okay, sir.
average, BMI mentioned. And when you say BMI, it's not kg per meter square. BMI is just a number. You don't have to
Yes.
mention. The BMI is 21. This is
Yes.
how you can mention it. Next slide. Now, once you've described the performance status and nutritional status, naturally, you have taken into account most of the factors that are relating to the nutrition. So this part is by and large routine. When you're mentioning arterial wall is not thickened, no radial or radiofemoral delay, it comes out in spontaneity, but that's okay. Next slide. Next, please. Next. Next, can you move it? Yes. When you say local examination, avoid using this term. It's for journal. In general, I try to tell students this. There's nothing like a local examination. You do a head and neck examination, and head and neck examination should start the same way. Symmetry or lack of it, and then overall any visible swelling or bulge. Mouth opening, as you mentioned. You mentioned 3.5 centimeter. But if you don't
Yes, sir.
mention inter-incisor, it will be wrong, no? Because you don't know which mouth
Okay.
opening you are calculating. So which one is this that you calculated? Inter-incisor?
Inter-incisor, sir. In between the
So you
central
need
orifices.
so you need to mention that. That is one
Okay.
thing which I wanted to add. And then you mentioned about, you constantly mentioning ulcerative form, right? You already described its ulcer.
Yes, sir.
Okay. And here you mentioned the right lateral border, 2/3 approximately, 1.5 into 1.5 centimeter, oval in shape. How can 1.5 into 1.5 be oval? It is absolutely circular.
Yes, sir.
Semicircle.
Yes, sir.
So,
Yes, sir. Absolutely.
extra words are the major reason for in English being responsible for your disaster. So you don't make it too complicated. First of all, it is not oval or circular because it's three-dimensional. So it is 1 point, just mention the size and we would know.
Yes, sir.
2.5 centimeter from the tip is a poor way to describe it. You usually describe lesions of the oral cavity in relation to fixed structures, that is teeth. So it extends from which tooth to which tooth?
Sir, sir, the canine to the first premolar, sir.
I
This
wouldn't,
should be tongue resting on the floor of the mouth.
Yes,
yes,
sir.
Tongue
that's right,
resting on the floor of the
absolutely.
mouth.
Yeah,
Yes, sir.
tongue resting on the floor of the mouth, measure it with the teeth. And if you say from tip, the tip is not by itself a fixed structure, right? So
Yes.
that is what I wanted to say. Note
Okay, sir.
normal tongue protrusion. So that is okay. Tongue, if you're saying tongue movements are normal, they include protrusion also. But I mean that's fine. If you mention normal tongue protrusion, that also helps. And coming to the, because you've described it as separately palpation, right? So
Yes.
we'll come there differently.
Sir,
The ventral surface,
for
floor of
other
the mouth.
PGs, right.
Yeah,
Sir,
yeah,
for
yeah.
other
Please,
PGs,
please.
I would like to emphasize this is the way you should start describing a oral lesion. It's not
Right.
that you just describe only the ulcer. You have to
Yeah, that's
describe
right.
about the symmetry, mouth opening, oral cavity as a whole. It's not only the ulcer to be described. This is the way you should go.
Absolutely.
And the head should be local examination of the head and neck because we'll be examining the regional nodes also. So don't
Yes.
jump only to the ulcer part.
Yes, sir.
Right.
Yes, sir.
If I was to, I mean, add to what Dr. Saha said, which is very important, is when you say local, you know what would local mean here? Local would mean ulcer only. So
Only the
here it's
ulcer.
a
Yes, sir.
complete, yes. So, but you're describing the entire
Yes, sir. Yes.
head and neck. So let's call it head and neck examination. Like in the lower limb, if you have an ulcer on the, you have a venous ulcer, then you describe it as examination of the lower limb. Breast,
Yes.
examination of the breast, not local. Okay. So that
Yes,
part
sir.
is to be highlighted. You mentioned very nicely about the loosening of the teeth. You mentioned no sharp tooth, loosening of teeth felt. I mean, this will confuse you. There is no loosening of teeth. That's it.
Yes, sir.
So
Yes,
otherwise,
sir.
it was looking like loosening of teeth was felt, which is what I thought earlier. Now, can you describe this ulcer again with everted, heaped up margins, base of ulcer indurated, not adherent to mandible? Now, what do you mean by, you put many things together, which is confusing. Describe the ulcer. Now, once again, just give a description. Once again, just describe the ulcer.
Yeah. I try to understand. Margin and age are two different terms.
Oh, okay, sir. Yes, sir. So the margin should be irregular, sir, and the age is inverted and
Raised from the
raised from the
ulcer
surrounding
floor.
ulcer floor, sir. Yes, sir. And base of ulcer is inverted, floored, but there is no slab on the floor, and the ulcer as a whole is not adherent to the mandible. And by ulcer size,
does it bleed on touch?
no, sir, it does not bleed on touch.
What would that signify? Suppose it was to bleed on touch.
Sir, pliability, sir. If the ulcer is deep and it has maybe eroded near to any
No.
vascular.
We are taking a lot of time. Why do malignant ulcers bleed on touch? Why are they friable and why do they bleed on touch?
What is there in the floor? The
Sir,
raw area, what is there?
necrotic material, sir.
No,
And due to
necrosis
that?
means dead. Why should necrotic material bleed? Why do ulcers that are malignant bleed on touch? It's one of their features, right? You should know this. This is a very basic question because of the neoangiogenesis. And these vessels
Yes,
have very weak, they're immature vessels. They're weak, friable walls. So they
sir.
tend to bleed. They're formed, but they're not ready and they're not matured. It's like, immatured vessels which tend to be weak. That's why they bleed. And most ulcers would bleed if you examine properly on touch. Okay. So therefore,
Yes,
I
sir.
asked you. So don't just again become a run of the mill. You should try to find as much as possible. Information should be correct. Okay.
Yes, sir.
What next? This is about and you said it's not fixed to mandible. I mean, it's a very crude term. It's so far away from the mandible, according to your description. Why should it be fixed to mandible?
Yes,
It's not.
sir.
You
It's
can
not
talk
fixed to
about
the
floor of the
floor.
mouth. Yeah.
Yeah, it's like floor would be more relevant. Mandible is far away, and you spent a lot of time trying to tell us about it not being fixed to mandible. So don't make it look so apparent that you're looking to, they say fitting a square frame with a round picture. So don't unnecessarily try to go that distance when it is not required. That's what I'm trying to tell you. Okay.
Okay.
Now what
Yes.
next? Tongue movement normal, and you said it is mobile. What is it? I mean, I would like to understand if you can expand on it.
Sir,
Tongue movement normal, mobile in all directions, and then
yes,
neck
sir.
came immediately after that. So keep that separately. And you can simply mention no cervical lymphadenopathy. Tongue movements are all normal. It's mobile in all directions. That's fine. I mean, there's nothing wrong in what you said. It really helps us understand the problem. But you should know what you are trying to say, not for the sake of completion. And I'm glad you mentioned indirect laryngoscopy. Why is it that? Why is it a part of clinical examination? Why should we have it?
Sir, for examining the posterior part of posterior 1/3 of tongue and the posterior most part of tongue, sir.
The
Sir, you
answer
will
to
not
the
get
question
this
is to
equipment in the
look
theater,
for
in the
field.
exam hall.
Yeah, so you won't get it. So when you're describing it and you want to score your marks, because it is described as a
But
part
he,
of clinical
unless he examine,
examination.
he cannot speak out in the exam.
So if you have not done it, don't say that. That's exactly the point. If you have done it, have you done it? You said normal. Ronit, have you done it? You're not answering that.
Yes, sir. Yes, sir.
Oh my good.
Okay, fine.
So if you have done it, we are delighted. But this is mainly to find out field cancerization or to look for another primary. Are you okay with that? Now you do understand? That's the answer to the question. Which is
Yes,
why
sir.
we do it, because the staging changes. If there are two cancers, it's a totally different. The staging pattern has undergone some changes in the whole policy. Okay, what next? Your summary, as Dr. Saha mentioned, is important that you mention about the neck notes there only, and then in the provisional diagnosis, don't need to mention the no neck notes without any neck. You can give the clinical stage here, CT and M. So what is the CTNM?
Sir,
What is the TN?
sir,
Yeah.
it will be T1 N0 by N0 M0, but sir, I cannot assess the depth by only the clinical examination. So for
Good.
confirmation, I'll need by either a radiological by investigation or by finally to confirm the biopsy is needed, sir, to find out the
You're right,
depth of.
because you need depth of invasion to give a proper TNM. Can you take us through the TNM?
Yes, sir. So
With
the
with the modifications of the present day
yes,
AJCCA
sir.
tradition. Yes, please,
Yes,
please.
sir. So TX is the primary tumor cannot be assessed. T0 is T in situ is in situ carcinoma. Uh, T1 is less than 2 centimeter in size and uh, less than uh, less than 5 millimeter in depth.
Mm-hmm.
T2
Depth
again
of
can be
invasion.
divided. Yes, sir.
Depth of invasion.
Depth of invasion. Yes, sir.
DOI, right?
Yes, sir.
Carry on, carry on.
T2A is uh, size is either by less than 2 centimeter, but depth of invasion is between 5 to 10 millimeter, or the size is between 2 to 4 centimeter, and depth of invasion is within 10 millimeters. Sir. Then
It's 5, 10, 15 and more, right? That is how you quickly wrap it up. And this was just a food for thought. We are not going to spend a lot of time doing it, but I
yes,
hope you understand that this would be a question that will be asked. So mention
yes,
the
sir.
CTNM here only so that you are sorted it out right there and then. Okay.
Yes, yes, sir.
Now, so your TNM is clear, and we have understood what you're trying to say about the staging. How do you proceed? What do you do
Sir,
now?
sir, firstly, I will do the investigations to confirm the disease, to stage the disease, and
Diagnosis. No, no,
yes,
no. You don't stage. Confirm the diagnosis, stage the
yes, sir.
disease, and
Yes, sir.
treat the patient.
Yes,
So
sir.
confirm the diagnosis, right? Not the
Yes,
disease.
yes,
Disease
sir.
is there.
Confirm the diagnosis. Yes, sir.
Stage the disease,
Stage the
treat the
disease
patient.
and treat the patient. Yes, sir.
So what do you do? Please keep rattling out
Sir,
so that we save time.
sir, for confirmation, sir, I will go for incisional biopsy from the edge, sir.
Right.
Then for staging for T, sir, I will need to do a CT scan or an MRI. Uh,
Mm-hmm.
by, for the N, sir, again, if not detectable by clinically or by USG, then I will go for a CT scan, sir. And
No,
for
no, no.
M,
Let's 1 minute. Good, good. You're doing fine. I mean, I just wanted to stop you for a moment. Can you
yes,
repeat the T part? What you said just now. I'm sorry, I didn't hear you clearly. Can you repeat that part, please?
sir, for the T, sir, by either a
Say CT
CT
oblique MRI. Say one.
city oblique
Yes.
MRI, sir.
Okay.
Yes, sir.
When CT, when MRI, I'll ask you later on. Next.
Sir, for the N part, sir, I will firstly I will do USG if it is not palpable by hand. If in
Mm-hmm.
USG there is an enlarged node, then I will confirm by FNAC. If it is not even detected by USG FNAC, then I will then CT scan might be helpful, but sir, I will by it will depend whether sir USG is operator dependent. So if I have confidence with the USG, then I will not go for the city. And for aim, sir, I can go for sir again for lungs. I will go for an X-ray. And if
Mm-hmm.
there is suspicion, then I will go for a CT scan, sir. And mm, uh,
No, if
and
you suspect chest
only
metastasis, X-ray is not the investigation to confirm test metastasis.
No, sir. Sir, fast investigation. I'm saying fast investigation, sir. To confirm, I will go for.
No, please understand. No, what he's saying is very correct. Because if you are doing it as a part of metastatic workup, then X-ray is not
Yeah.
optimum. No,
Okay, sir. Okay,
if
sir.
you're doing it as a routine, which you will do anyway, every patient will have X-ray chest for surgery or otherwise, then it's a different story. But as a metastatic investigation, it would be inadequate. That is what he's saying. Okay,
Okay, sir.
right.
Okay, sir.
So you would do investigations to confirm the diagnosis, and you were very smart in mentioning T, N, and M. But always say when you're saying CT, ultrasound, MRI, whatever you're saying, always say imaging, and so that you get a broader, base to take care of yourself, and that can be really helpful in saving you from saying CT or MRI. First, you're saying ultrasound, I'll do, right? Ultrasound
Yes,
is
sir.
for the neck, and that's probably the most reliable investigation for lymph nodes, not clinical examination. I agree with you.
Yes,
We all
sir.
agree with that. And when do you do CT and when MRI? Any idea?
So CT scan, MRI is better for soft tissue involvement. So
Right.
if I am not suspecting a by involvement of the mandible or maxilla, then I will choose the MRI, sir. But if I
So
am
they are
by
so they are complementary, right?
yes, sir. Yes, sir.
So they're complementary, and for nodes, sometimes people say CT is better, and for
Yes,
bony erosion, soft tissue of the tongue, like floor of the mouth, soft tissue of the tongue, it is better to have MRI. So you should be flexible, right? Okay.
yes, sir. Yes, sir.
But before that, let's look at the incisional biopsy. Can you show the
Yes, sir.
picture and tell us where we to take the biopsy from?
Sir, from the age of the ulcer, sir.
Which age? Anterior age or posterior age?
Make it a habit, Ronik. You're a good student. Always complete your answer. Anterior edge, posterior edge, medial edge, lateral edge. So don't just say edge. Mention which edge. Like Dr. Saha immediately asked you, which edge? So you said edge. Edge can be all around, isn't it? So which edge?
Sir, anterior edge, sir.
Yeah, I already said that. But why anterior edge? Why not posterior edge?
Sir,
Some
I'm
questions are
not.
common sense questions. No problem. So basically, every time that your intervention is there, you're also taking into account your subsequent surgery. You don't want the margin to extend posteriorly. You don't mind
Yes,
it going anteriorly because
yes, sir.
posteriorly it will be hard to access and also the morbidity is more. So we take an
Yes,
edge
sir.
biopsy from the anterior edge. How is it different from wedge biopsy?
Sir, wedge biopsy, sir. Wedge biopsy is taken for mm, a proliferative
See,
lesion, sir.
Ronik, it is not my question. And I don't fancy this question very much, but I'm providing you questions of other people. So some
Yes, sir.
people like to take a little W of the whole thing to make sure that you get some normal tissue and abnormal tissue so that pathologists can compare it. But now there is something more added to it. Sometimes you have the in situ cancer away from the grossly palpable disease. So it is therefore a lot of people recommend it, but you should know about it. All of these are part of incisional biopsy only. They're all
Yes, sir.
incisional biopsy. So you've taken
Yes.
an edge biopsy, Ronik, and the pathologist has reported it to be equivocal. Says, I can't give you a confirmation. So what do you do next?
Sir, again, I will repeat the biopsy, sir.
Give a
Good.
course
The
of antibiotics.
pathologist is also a goofy. He gives the same report. Now what do you do?
Sir, but then I will go for excision with a 1 centimeter margin, sir.
So that's what I wanted you to say so that I can teach others also. This is an absolutely wrong answer. So don't give that answer. No excisions are done unless you're aiming at cure. Excisional biopsy is done only when the lesion is extremely small. Otherwise, in this
Okay.
case, it will amount to a proper surgery only. So it is not correct. Equivocal diagnosis in oral, head and neck, tongue cancers or penile cancers is very common due to superadded infection. Dr. Shah gave you a hint also, but you probably did not listen. This is due to superadded secondary infection. Therefore, you can repeat it after putting the patient on Listerine mouthwash giving a course of antibiotics so that you can get a diagnosis. You definitely do repeat, but mention that I'll do this after making sure that superadded infection is taken care of. Is that okay?
Okay.
So
Okay, sir.
you've taken it, because let's first get the biopsy sorted. It's very important. How do you test for HPV? Suppose now we are wiser these days. There's an HPV cancer, there's a non-HPV cancer. So what do we do?
Sir,
Any idea?
sir, for the we check for the proteins, sir, P6. I'm
Read about it, because this is theory. So do read
yes,
about how do you test for HPV. Yes, you're right. You're close to it, but mention them correctly. Now,
yes,
you've done the edge biopsy, and now T is done. For the nodes, you said you do an ultrasound first. What ultrasound features would indicate you, first of all, clinically didn't have a node? So ultrasound would show that there is a node. And once you found the node, what features would indicate that it is a metastatic node?
sir. It will be taller than wider, so then there it will be irregular in shape, and
Mm-hmm.
there will be loss of
Normal bean snippet. What happens to the bean?
sir,
Look, Ronak, you probably, without understanding, if you cram up, then there are problems. This taller than wide is a good idea for a lesion. A lymph node naturally is taller than wide. It is by its own shape. It is, as Dr. Saha mentioned, bean shaped, or you can say kidney shaped, or then you will be asked, what is bean like? You will say kidney like. And what is kidney like? Bean like. And what are they? They are like each other. So that goes on. You keep on giving a simile. It's basically, in any case, ovoid, right? So
yes,
in malignancy, it becomes spheroidal because of excessive, proliferation close to the hilum, and also due to central necrosis, it will swell up to become spheroidal. That's one. Number two, there is an area of there's a hypoechoic area in the center of necrosis. Then
yes,
there's a
sir.
loss of capsule, because extra capsule spread may happen. That's called halo sign, loss of halo. And
Yes, sir.
then, of course, the architectural distortion, and fatty hilum is replaced by proliferating vessels. So you should know about it. This is why, you simply mentioning ultrasound is not going to help, because this will be asked, although your
Yes,
answer is correct. Now, in a suspicious node, you can do an FNAC, you are right. But otherwise, clinically, no longer we call any disease as node negative unless you've done an ultrasound, right? What do you do for
yes,
the M? You already mentioned. What do you do for the M?
sir. For the AM, sir, CT scan.
So X-ray chest is wrong, no? So, and we don't do CT thorax routinely. What are the indications for doing CT thorax in patients of head and neck cancers?
Sir,
Yes, sorry. Dr. Shah was saying something. Yes, please answer that.
Yeah.
Yeah.
What
When
site
do you
is
do
important?
CT?
sorry,
Yeah.
sir.
What are the indications for doing CT thorax in patients with head and neck cancers? And Dr.
Sir,
Shah asked one more question to that. What size? So T size would make a difference. He's given you a hint. What T size you should do a CT?
sir,
You just don't do it in all. You don't do metastatic workup in all cases, no?
no, sir. Sir, by T3, sir, at least.
T4, and sometimes with the lower metastasis. So, like level 4 is involved by lymph nodes. You need to see the, thorax, the involvement in the thorax. Also, the histological grade. Please do some reading. These are takeaway questions which you should know. So don't mention CT thorax in all patients of head and neck cancer. It is not common to see, or if the patient is symptomatic. If the patient has got cough or breathlessness and hemoptysis, as you mentioned, then you
Yes,
do that,
yes,
right? So TNM is what you do, investigations for clinical examination for TNM, and investigations for TNM. Now, this is your case. Now, your stage is correct. It is moderately differentiated squamous cell carcinoma, which is what we expect. It's non-HPV. What do you do? So what do you do to manage?
sir. I will go for sir white local excision, and for next, sir, since it is N0, then I
Specify the
will go
margin.
for
Specify the margin. While you're
Actually,
saying, okay,
very
margin of
Yeah.
Wide
Even
local
wide local
excision with
excision,
1 centimeter. Wide local
Ronik,
excision with
Ronik, 1 minute.
1 Yes, sir.
Ronik, 1 minute. First of all, even that is not correct. Wide local excision is not correct answer because three-dimensional clearance. Wide local excision is flat. Three-dimensional
Okay.
clearance, which means in all directions, with a
Yes, sir.
margin of 1 to 1.5 centimeters. In tongue, we take a little wider, no? And
Yes.
right, and
Yes.
that is for the primary. What you're going to do? What are you going to do for the? Okay, you complete your answer. Sorry, we stopped you there. So wide local
Sir,
excision with a three-dimensional clearance, so 1 to 1.5 centimeter all around,
yes.
and
For the neck, I can either go for, sir, elective neck dissection of
This patient, what are you going to do? You said
sir.
N0, confirm N0 on imaging.
Yes,
Is there a
sir.
role for taking a elective dissection of node? If so, how long? How far?
Sir, elective neck dissection has been proved to be better than wait and watch. So, sir,
yeah,
I
that's right. But that's not his question. He asked you, in this patient, how are you going to go? Don't talk about
sir,
what is written in the textbook. He's
yes,
asking a
sir.
specific question. He's asked you, he's giving you a scenario. Tell us about this patient. We don't care what you do in theory. In this
In a
patient, give us a
N0 neck,
complete
what is the
answer.
recommendation? In N0 neck, what is the if you are doing elective, how far you should resect?
Sir, by level 1, 2, and 3, sir. And
Okay, that's not that's wrong, Ronik. But I think I'll save you when you're saying elective
sir,
neck
another
dissection.
option would be sentinel lymph node biopsy, sir.
No, please let me. We'll
Okay,
not
sir.
jump there. We'll go slowly. First thing is you talked about the primary. You can do a wide local excision with three-dimensional clearance of 1 to 1.5 centimeter, and depending upon the extent of resection, with or without reconstruction. So that you should mention. Firstly, the
Yes,
primary should be properly done. Because if
yes,
there is
sir.
more than 20 to 30% tongue loss, we need to do reconstruction. You should know that.
Yes, sir.
And
Yes.
reconstruction done with local flaps or, the
Or predicate or free flaps.
free flaps or free flaps, right? So that
Yes,
is
sir.
simple. Next is, if you're going to do and addressal of the neck. Addressal of the neck is usually in the form of either a diagnostic neck dissection or a therapeutic one. Okay. Now,
Yes,
since it's
sir.
an N0 disease, so you're going to do a diagnostic neck. And
Yes.
there you do, all of them are covered as selective neck dissection these days. The terms
Yes, sir.
like supraomohyoid, ultra supraomohyoid, etc. are no longer used. So you do
Yes.
selective neck dissection. And in tongue, it's not 1, 2, 3, it's 1, 2, 3, 4. Everywhere else, it is 1, 2, 3. So why is it 1, 2, 3, 4 in tongue?
Sir, there can be skip metastasis to
Good. So why are there skip metastases in the tongue? Why is it common?
Sir, in tongue there are multiple channels of lymphatic spread, sir. There,
Good
the
one. Number two,
apical
you
channel
have
will.
answered that. Are you done? Next reason.
Sir. Mm.
Tongue is a mobile structure which keeps moving, so the lymphatics, due to churning effect, can keep getting pushed. And
Yes.
sometimes due to the pump effect, as they call it,
Okay, sir.
they may jump to the level 4. The skip may happen.
Okay, sir.
Right, and tip has a bilateral supply, you know that. It's a
Yes,
drainage.
sir.
Tip has a bilateral drainage. So that's another reason. What
Yes,
else?
sir.
So you do selective neck dissection, which can
Yes.
be level 1, 2, 3, and 4 here. The older
Yes.
term used to be supraomoid neck dissection, which was 1, 2, 3.
Yes,
And
sir.
that was called ultra supraomoid when we did 1, 2, 3, 4. Yeah?
Yes, sir.
So,
Yes.
and I've already told you about reconstruction, which will happen if it is more than 20 to 30%. They say 30%, some people say 20%. But
Yes.
functional aspects of the tongue would suffer if we take out too much of tongue and we don't stories. Okay.
Yes, sir.
And can you hear me?
Yes, sir.
And the surgery would be this, and it's good to add, depending upon the histology, patient may receive adjuvant radiotherapy.
As you already
That
talked, yes.
usually takes care of it. But when you're saying the management, you should always start by saying that I'll ask the patient to stop chewing tobacco, regular antiseptic mouthwash, preparing the patient for surgery, and discuss the case in the MDC so that the decision it's not
Sir, sorry, sir, your voice is
that sounds a
breaking.
little better. Or still breaking or it's better?
No,
Is it
sir, it's
better now?
still breaking.
Can you hear me now?
Yes, sir, I can hear you.
Yeah,
So
yeah.
basically, I'm saying
It's breaking.
included in your first go so that
Okay.
it's clear to the examiners that you're aware of it. All
Yes,
right.
sir. Yes,
I
sir.
think that's that. What are the various flaps you can use for tongue deconstruction? What are the
Sir,
flaps you can use?
sir, radial forearm flaps, sir, and pectoral is major myocutaneous flap. And if the defect is small, I can use local flaps, which are such as the facial artery myomucosal flaps, sir.
Right. What are the other options? If not surgery first, can you give radiation first? What are the problems and whether you can give it or you can't give it?
Sir, surgery is preferred, but if the patient is not fit for surgery or performance status is very poor, then we can consider to go directly for radiotherapy
So
or
in
chemotherapy.
tongue, what are the situations where you can go for radiation upfront?
Which part of tongue is preferred treatment is radiotherapy?
Sir, by posterior part of tongue.
Posterior third, base of the tongue.
Yes, sir.
Right.
Yes, sir.
You see, for upfront radiation, it's a T1 or early lesion
Yes, sir.
involving the tip, where you can give
Yes,
external beam radiation to the tip.
yes,
For the
sir.
base of the tongue and oropharynx, the management is, of course, chemoradiation. So that is a different disease we are talking about. In the anterior third or the oral tongue, malignancies are managed by surgery primarily. So my
Yes,
question was, where do you go for upfront radiation? So one, you may answer correctly, where we suspect the problem to be patient to be having a very poor performance status and the outcome expected not to be very good. So you have a reason there. In addition to this, situations where it's a very early lesion and patient has comorbidities, not fit for surgery, you can go for radiation. Otherwise, treatment of choice is surgery. And this
Yes, sir.
lesion looks very comfortably placed. How would
Yes,
you assess the margin here? What would be your margin? When you look at this ulcer, your picture is shown. It's the indurated part. Margin is the indurated part, and beyond that, you go. And when you described your ulcer, you mentioned that the base is indurated, but you should mention the induration extends beyond the boundaries of the lesion, and it is non-tender because tender would be inflammatory, and extending beyond the boundaries of the lesion is likely to be malignant. That is infiltration. So this is another thing that I observed you could have mentioned. I
Yes,
think
sir.
by and large we've covered. If there is anything that Dr. Shah would like to add.
In this patient, you have done a curative surgery with a node dissection and nodes are all negative. What should be the plan for any adjuvant treatment in this patient? Any indication?
Yes, sir.
Post-op adjuvant?
Sir, if there is in this case, if there is no neck node that rules out the multiple lymph node criteria. If there is extranodal extension, again, that's a criteria.
No,
But
he
here
asked you a
no node is.
question. No,
This
you've done
patient.
the node dissection, but it is negative. All is negative. So, what is the adjuvant treatment that you would advise? So it becomes a PT, whatever at PT stage, and N0, M0 disease. So would there be an indication for radiation or not? We can be direct with it.
Sir, if the in this case, sir, since the tumor size is small and there is no nodes at all, radiation therapy is
See,
not.
now, Ronek, what are you going to become? A surgeon or a radiation oncologist?
Sir,
You're
surgeon,
going to
sir.
become a surgeon. So you
Yes,
should
sir.
say, we'll discuss it in the MDT. And
Yes.
based on angiogenesis, lymphovascular invasion, grade of the tumor, the decision would be taken. But in all probability, lesion being very early, and I have achieved a R0 resection, I may not
Yeah.
need to, in the margin, one thing I'd like to ask you, oral cavity, tongue especially, there's something called as a stretched and a non-stretched margin, because usually we hitch and send it, because once the specimen goes in formalin, it shrinks, and the margin can be an issue. So therefore, you can mention that if you want to score a distinction. But that will happen only after you've done your basics right.
Yes, sir.
So
Yeah.
that is, so adjuvant therapy would depend on what are the morbidities. If you give, okay, I forgot to ask you, we drifted from there. Upfront radiation we've discussed. What are the disadvantages of upfront radiation, even if it is indicated? Radiation, the primary therapy, not as adjuvant, please understand. As a primary therapy, is a very high dose with a lot of morbidity. What are the morbidities following radiation?
Sir,
Head and neck?
sir, it may lead to, sir, submucous fibrosis and all. Sir.
No. You know what is called a Sika syndrome, no? Mucositis,
Yes, sir.
all
Yes,
the secretion would dry up.
dryness of
It'll
mouth.
become an
Yes.
absolutely dry head and neck. The tears would stop coming. He'll have a patient has a terrible time. And the dose you're going to give for the primary as well as for the neck is going to be extensive. So therefore, one has to give only in the form of adjuvant radiation, which is usually a smaller dose. Is that okay?
Yes. Yes, sir.
Right? Dr. Shah, can we stop there? Or
Yeah. Yes,
I'm at
yes,
your
sir.
service.
9, past 9.
I've reached the theater. So now I am comfortable in place. Okay. Thank you. Thank you so much. Well presented, Ronak. And we just wanted to correct certain things which would be useful for you. But otherwise, by and large, you made a good presentation. And everybody, I'm sure, others also benefited in the same way.
Thank you,
Thank
sir.
you. Thank you, Dr. Shah.
Thank you, sir.
We'll catch up
Thank
with
you.
your permission.
Thank you, sir. Thank you. Thank you.